Bismillah ar-Rahman ar-Rahim. I think you will hear more about complications of mini gastric bypass and its management, but today I will have a lecture about reversal of OAGB or mini gastric bypass. Recently, it was a consensus that about the name of the procedure, and mostly it is named OAGB. Although Carbajo tells OAGB is my procedures and mini is the Rutledge procedures. And when we should do reversal, failure of the procedure, mostly we use mini gastric bypass for weight loss. So if we have failure, it means and to my time, how many minutes?
10 minutes, as you like.
10 minutes, yes. When we tell you had a failure, when your patient has less than 50% of excess weight loss or BMI more than 35. But its failure is very lower than sleeve gastrectomy and less than gastric bypass. Or you may have regain. Regain also is very lower than sleeve gastrectomy and less than gastric bypass. Malnutrition is a major problem because mini gastric bypass is mostly malabsorptive, and you should see if your patients had malabsorption, and it may have different presentation. Hypoalbuminemia may be a major presentation with edema, and you may have NASH. You know that with hypoproteinemia is a major reason for NASH and leading to cirrhosis. So you should, if I had time tomorrow, I will show you the database and also its graphs. You should see if your patient's liver enzyme is increasing. It's an alarm to you to reverse the patients or make a good consultation with nutritionist. Anemia and other problems may be a sign of malnutrition. In Chevalier, who has presented more than 1,000 cases of mini gastric bypass in his series, about 0.2% had malnutrition. Another thing is severe weight loss, which is about less than 1% in Rutledge series. Contrary to Roux-en-Y gastric bypass, in our patients follow-up, we see in Roux-en-Y mostly weight regain. But in mini gastric bypass, we see more patients with severe weight loss. So it's another reason to do reversal. Bile gastritis and afferent loop syndrome, which professor said in the first session, is another reason to think about reversal. About 1 to 2% of patients complain of bilious vomiting once in 2 or 3 months, and for refractory cases, it means less than 1% you should do reversal or procedure like changing to Roux-en-Y. Marginal ulcer is another reason. It's estimated 1 to 6%, and although it is mentioned in literature that it's same to Roux-en-Y gastric bypass, but in my experience, I've seen the risk of bleeding and marginal ulcer early post-op is more in mini gastric bypass. As we learn, more acid, more ulcer. And so when you have a larger pouch, so I think the risk of marginal ulcer will be increased, although in the literature it showed same as Roux-en-Y, but if I have enough time I will publish my experience, and in our experience,
Discussion will give you more
yes,
time.
yes, yes,
You
yes,
accept our
yes,
discussion?
yes,
You accept?
yes, yes.
Can I ask another question? What's the difference between revision?
Revision, reversal, and revise. You, for example, reversal, it means completely reversing to the normal anatomy. But revision is changing to another procedure. For example, changing mini to Roux-en-Y or changing to a sleeve gastrectomy. Other reasons are dumping syndrome, anastomotic strictures that are very rare, nasodioblastosis. One of the, at first, they told that risk of nasodioblastosis, you know that our patients may be prone to hypoglycemic crisis, and it is named nasodioblastosis that is seen less than 1% in Roux-en-Y gastric bypass. Previously, they told it is not seen in mini, but at present we have seen some cases of nasodioblastosis, although you should differentiate nasodioblastosis from dumping syndrome that may have the same features. But the history differs. And the symptoms when present with drinking sweet liquids, it's dumping, and otherwise it is nasodioblastosis. Intolerance of the procedure is another reason to reverse the patient. How should we do? Complete reversal is very rarely needed. Only if you have very complicated cases you can do reversal. And in our experience, when we have malnutrition, severe weight loss, we do gastrogastrostomy. As professor said in the morning, you have the choice to make less malabsorption by decreasing the limb of biliopancreatic. For example, from previously at first they told all the patients should have 2 meters. But when I started, after a few months, I saw that we should change our protocol, and from that time, regarding to BMI and also the age of the patient, another criteria is the age of the patient. If your patient is more than 50 years, you should lower your malabsorption and the length of limb should be decreased. And for such cases, we have a good, very, very good experience with gastrogastrostomy in our country, and very well. These patients after the operation will be very well, and all the signs of malnutrition and severe weight loss will reverse. Conversion to Roux-en-Y gastric bypass, it's very good for bile gastritis and afferent loop syndrome, and you can use it easily because the half of the procedures have been done previously, and you change it to Roux-en-Y. About marginal ulcer, I had a case that I operated. She lived in Switzerland and she came to Iran. I did for her mini. When she came back to Lausanne, Professor Qawami, who is my friend and one of the best, who is the president of Francophone MIS surgeons in Europe called me that she has refractory marginal ulcer, and he did for her Roanvoy and converted mini to Roanvoy, and her marginal ulcer fortunately was resolved. But it is an experience, and mostly we when we have refractory marginal ulcer, we resect and change it to a less gastric pouch to decrease the risk of marginal ulcer. Rare procedures, conversion to sleep for refractory nasodioblastosis or dumping syndrome is a good option. Bronchojejunostomy is not recommended. We had a research and we did randomize the patient. We randomized the patient to brown and not doing any procedure, and we have also bile gastritis in brown patients. So brown jejunostomy, I think, is not a good option, and if you have bile gastritis or afferent loop syndrome, it's better to convert to Roanvoy gastric bypass. Conversion to distal Roanvoy gastric bypass or BPD duodenal switch for failure or weight regain is recommended, but we didn't have any cases to do so for him. And I will show you a video clip.
Can I ask a question?
Pardon, it is edited by my flowship, so, and I'm a student, not professor, every time. Yes. If possible, after the video, you see here we are when you do laparoscopic procedure, the adhesions are very less. It's not sure.
So, Bazooki, can I ask questions?
Yes, professor.
Just about the brown anastomosis.
Yes.
I mean, if you ask Rutledge, he will say, I will never converted any patients to Roanvoy gastric bypass.
Yes.
Patients with MGB patients that develop bile reflux, he said, I will do brown anastomosis. And for audience, brown anastomosis, side-to-side anastomosis, 50 centimeter from gastrojejunostomy. The surgeon was working in King's College in South London, actually. We discussed a case, he recently has a case, MGB, and she had bile reflux, and he said, I converted her, I did brown anastomosis, but she didn't resolve, so I have
Yes.
converted to Roanvoy gastric bypass. This has confirmed your view about
Yes.
converting MGB to Roanvoy rather than to the brown anastomosis.
Thank you.
Primarily, if you do MGB and you do brown anastomosis with it, this is not MGB anymore. It is not one anastomosis,
Yes.
single anastomosis gastric bypass anymore. This is a different kind of a procedure.
Yes.
And you can't prevent presumed bile reflux in the future by doing brown anastomosis. We know from largest MGB series, thousands of patients, the incidence of bile reflux is less than 3%, and patients who need actually reversal of Roanvoy gastric bypass because of bile reflux is in the region of 1 to 2%.
Thank you very much. I had a case with bile gastritis, and it was a study and not was routine. We wanted to see the role of brown jejunostomy on reduction of bile reflux. It was only a research, and we randomized the patients. 76 patients was chosen, and we saw that it has not significantly decreased the bile gastritis. You see, she was a young female with excessive weight loss and not tolerating the patients. She wanted to completely reversal, and she had elevated enzymes and low albumin. So you see here, you have less, very few adhesions because you have done laparoscopic procedures. Fortunately, we can completely divide the gastrojejunostomy, and without if you think it's stenotic, you should do jejunostomy, and you see there isn't any stenosis. And here we are dividing the pouch from remnant. Here we are doing gastrostomy on pouch side. Here this is the pouch side, and this is the remnant. You see here we are doing gastrostomy on remnant. Harmonic is a good tool for doing gastrostomy, but with hook also you can do the same purpose. And side to side gastrostomy. Fortunately, if you do gastrostomy with 45 millimeter stapler, the patient will not be so fat, and it works like a vertical banded, and between the pouch and the remnant you will have a very small connection. As in open surgery, you know, we in our experience we do 2-layer when we want to do gastrojejunostomy or jejunostomy, we use 1 layer, but for gastrostomy we always use 2-layer because of risk of bleeding. You know, stomach has a good circulation, and it has, so we take the first layer full layer and the second layer to invert the first layer.
What was the indication of reversal in this particular
As
case?
I told you, malnutrition and severe weight loss, and you will see the liver has also some changes. And
What was the pancreatic length?
2 meter. It was among our previous cases that we routinely, as it was recommended at that time, all the patients 2 meter.
Why you did the shortening of pancreatic length rather than complete?
Because the patients wanted completely to reverse the procedure, so it was only because of that. Otherwise, as I told you, in our recent cases, only we do gastrostomy, and it will reverse all the changes, both weight loss. You see the liver is abnormal, so we do biopsy, and you know the needle biopsy is more accurate than wedge biopsy. So we did biopsy for her, and 2 biopsy was done. This is the second one, and then putting the drain. Thank you very much. Any question?
Any question for Dr. Abdullah or Dr.
Nicely done, reversal. For the audience, as you can see, reversal again is very easy for this procedure. imagine this is ruled among gastric bypass patients who had complications and you want to reverse it. It will be lengthy procedure and you're asking for much trouble. In that case, you just dismantle the anastomosis, above the gastrojejunostomy, and you just create a new side-to-side anastomosis between the pouch and remaining stomach. You close the hole. It won't, I'm sure it didn't take longer than 20 minutes in your hand. Your experience hand, 20 to 30 minutes.
Is that you follow your patients about their liver enzymes?
Yes.
What was that?
You know, and I think you don't know. Because the first case report of mortality after mini gastric bypass was reported by our department, and also the second case we prepared the data from one of our professors, Dr. Khalaj, and also it was published in the literature. We have seen two types of liver insufficiency. Two was cholestatic and two were only NASH, like NASH. And the prognosis after cholestatic types seems to be poor, more poor than only raising the enzymes. And it may be due to malabsorption. You know, one of the most prevalent reason for liver cirrhosis is malabsorption and hypoalbuminemia. And we think at least one of that reasons is hypoalbuminemia that was seen in our patients. Yes.
Thank you, sir.
Thank you very much.
Any comments from the audience? Yes.
Professor Bازوكي, please. If you have any idea about
سيد بتزعيم زنا.
About the liver reflux
Yes.
and the efficiency of the Brown procedure.
Yes.
You change the size of anastomosis by lengthening the length more than 50 centimeter, and so the efficacy of the side-to-side anastomosis. If we length more than 50 centimeter, we may get rid of the biliary reflux.
Yes, we did. Our distance was 30 centimeter from gastrojejunostomy for Brown. Recently, one of my fellowships, Professor Abdul Hosseini, is doing another type of Brown and a modified mini and with the different limbs from afferent and efferent limb. It looks like a circle and more longer on afferent limb than efferent. He told me that this makes the risk of bile gastritis less. But if we lengthen, we should see, we should do research, and when we done an RCT, we can tell about the results. Yes.
I have a question. Do you
Yes.
check the patient for GER before doing the procedure for mini bypass?
Yes, we do for all our patients upper GI endoscopy. And it's very necessary, you know, if you have, for example, Barrett esophagus, it's a contraindication to a sleeve. Or when you see, we do biopsy for our patients, and sometimes you will have dysplasia in your stomach, and these patients should be done for them every 6 to 12 months endoscopy to see the progression of dysplasia. So we do for all of our patients upper GI endoscopy, and they are evaluated for GERD endoscopically, and also we ask in our database, we have a place for heartburn. If the patient has heartburn, we prefer to do bypass procedures from sleeve, yes. Runway or mini. Recently, there was a consensus was published on obesity surgery about mini gastric bypass, and from our country also, two of my friends and my fellowships was also among the persons who had voted about the different. And about GERD, it's the consensus was even you have GERD more than grade B, you can do mini. The consensus without. Brown is, as Professor said, is not included in mini gastric bypass.
Yes.
Thank you, both. I have a question to Lucia and to Professor Karzar. You know that the leak in the gastrojejunostomy cases of mini bypass, I think it is more critical than the leak in the gastrojejunostomy of Roma. You have a bile in the leak, you cannot use a mesh, a stent. Do you have cases of leak in the gastrojejunostomy and how you manage it?
Yes.
Do you compare the case for cases
Yes.
of leak in the gastrojejunostomy?
Yes, although professor didn't have any leak, but because we have a educational center and we accept complications, and every person from different side of country, if have complication, consult with us, and we had some cases of leakage. Both, some of them from grasping for leak test, for example. When you grasp for leak test, you have more pressure to resist against the pressure of the methylene blue or air, so it may injure. We have two cases, and it has a fistula that last week we did laparoscopic management of this fistula after 4 to 5 months after the leak, and also it was he had open abdomen management, and then only a fistula that we managed it, alhamdulillah. When I was coming, my friend emailed SMS to me that the patient was good and discharged from hospital. And also we put drain, it's very important. Tomorrow after the operation, we give the patient methylene blue. In my opinion, it's better than previously we used gastrographin and water-soluble contrast to check for leak. But we had a case of aspiration, and he was one of the major military men in Iran, Sardar Firuzabadi, who was and after that he had aspiration, pneumonitis, and we had managed him, alhamdulillah, for 4 days critically. And after that I do only by methylene blue. Another case that was by grasping, the day after the operation had methylene blue leak came from drain, and my fellowship did it very easily, only sutured it. And also we have leak from gastrojejunostomy. I don't think the rate of leak be more, but we have, because you have less tension. Your pouch is longer. If you do correctly, you should do from below the incisura, and it's will have a more longer and less tension on your anastomosis. But we had also leak on it, and maybe I have done today. I saw my last data, it was more than 1,500 cases of mini, and I think I should, it's not completely recorded. I should see completely. I think about 5 or 6 cases I had leak in gastrojejunostomy. In such cases, if you have disruption, sometimes you have disruption. For example, the thread was completely broken and the anastomosis is completely open. In such cases, we dismantle and do Roux-en-Y completely. Otherwise, we only suture the defect and put an omental patch on it. Omentum, the best omentum is from behind the loop. You know, when we have leak, the leak material comes down and the omentum behind the loop is protected by the loop. It was not dirty by the leak material. So it's a good omentum, and you can put it as like every peptic ulcer disease. And then every time, in our experience, it's better. And I recommend it to my fellowships and all the surgeons who are member of our society or in the Congress. We always convert it to Roux-en-Y. Always, because as you mentioned, the risk of leak when there is a blind loop without any bile, without any pancreatic enzymes, is for healing is more. And even if the leak persists with a drain, it will be managed.
Dr. Abzal, you would anti-tube for mini bypass?
I just use the bougie to test the anastomosis during the procedure, and that's it. I ask the anesthetist to pull the bougie before I pull my port, because I want to make sure that the bougie is freely mobile, it's not taken by stitch or anything. So that's very important, because although you move the bougie during the testing, because you have to test the gastrojejunostomy. Once you finish the anastomosis and the bougie is stopped in the common channel, you ask the anesthetist to pull the bougie 2 centimeters before the gastrojejunostomy. You test the anastomosis, and then you put the displantus or the delicate forceps above the anastomosis to test your sleeve, the pouch, the long pouch. And then you ask the anesthetist to pull the bougie to 40 centimeters to test the gastroesophageal junction. This is the most area of the anastomosis to make sure it is clear, there is no injury, there is no leak. And as the professor correctly said, I will put a drain in any case, in every case. The drain can save the patient's life, can save your life, because the drain is a warning sign. Some of the patients...
We saw you are putting tube drain.
Tube drain. I use it. I am a big fan of corrugated drain as a professor.
Yes.
Unfortunately, my trust doesn't support corrugated drain. They can't bite for us, and they are just total with no protection, as we discussed before. But one important point regarding the leak after MGB. One of the major points, the difference between the leak after MGB and the leak after a sleeve is if you go to the studies, and one of the largest studies, 4,500 patients, the incidence of leak after a sleeve gastrectomy after 4,500 patients, meta-analysis is 2.4%. If you go to MGB series, largest series with meta-analysis, the leak rate after MGB, the average leak rate is less than 1%. Why? Because we are dealing with 2 different systems. As the professor correctly said, with MGB, it is low pressure system. You have wide gastrojejunostomy. The pylorus is completely abolished from the pathway. If you have even minor leak, possibly is not going to show clinically. and it will heal by itself. In sleeve gastrectomy, the story is different because you have the pylorus, high pressure system, and if you have a leak, it is disaster. It will show itself even if it is minor. And I have very bad experience with leak after a sleeve, not from our cases. We have done 500 patients, but we do suture the...
How much was the leak? 500.
In our cases, the leak rate is 0. This is King's College Hospital, South London.
Doctor,
Why?
do you accept leak 2% and sleep?
Yes, I think it is around 2%.
In your series,
I have just 2 cases of leak.
amount, how much?
After?
Thousands?
No, it's just down 1,000.
Less than 1,000. So, it's less than 1 per 1,000.
Which is very good. I mean, even this better than Ganya study, which showed the leak rate is up 1.5 or 9%. I think in our case, we are too obsessive in South London. We don't depend on just the stable. We put another layer to overrun the sleeve stable line from the gastrojejunostomy up to the
Not
input.
more recommended. To our showing the stable line. To not invert it for leak.
No, it is not.
Yeah, they say it is more hemostatic rather than leak.
Well, it is both, to be honest with you. My personal view, it is hemostatic, and in our series, it prevents leak. But then, I mean, the professor, he knows, some of these studies are biased, actually. Ganya study, he is a consultant to Gore, and Gore producing these putrescing materials. And he showed in one of his largest study, 2,000 patients, that the leak rate will be less if you use putrescing material. But our personal experience with 500 cases without putrescing material, leak rate is 0.
دكتور نصير عندي سؤال آخر معه. سؤال أستاذ.
Thank you very much, Doctor. Please, I ask, for how long you remain in the drain? Would that corrugate the drain?
Corrugate? Yes.
For how long? If you face the question,
Yes.
I'll ask you a second question.
Let me tell one by one. For corrugate, previously we used tube drain, like Nelaton. But it didn't work, and I had a patient, even for cholecystectomy, the patient was uremic and he had bleeding after the operation. He had a huge hematoma in his abdomen and nothing came from the drain. We changed to corrugate drain and silicone soft drain. These are very soft, and these are the best. Even I used Jackson Prot, which is a good drain, but even that drain doesn't work for me like a corrugate drain. So I always use corrugate soft silicone drain.
For how long will you?
I started laparoscopic bariatric surgery from 10 years ago, 11 years ago, first case. So it was on سال 86. And then I think after 1 or 2 years I changed, and even when one of our fellowship advised that Jackson Prot is very good, and I have seen in Europe my professors use Jackson Prot, but I used them and I saw that corrugate drain works better than them.
So it means in the same patient, when you will remove the drain?
What?
When you will remove the drain from the patient?
When removing the drain, mostly the first post-op one, and after leak test. But sometimes if I see it's dark bleeding from the drain, I remain the drain, although it have the risk of infection, but it's very, very, very low. And I discharge the patient, or I may have, we can talk about the bleeding, extraluminal bleeding in another session. And when it was serosanguinous, I will remove the drain.
Thank you. Regarding the oral intake, the second question is regarding oral intake.
What?
For the oral intake of the
Oral intake, yes.
for the general straightforward surgery, and for that complicated that gets leak and you revision the anastomosis, or what do you do?
Yes.
Where is that oral intake?
For my patients, for all of my patients, the day after the surgery, they have leak test, and if it is what it was negative, we start oral liquid diet. And when we have leak, I have only 2 cases of my my mini gastric bypass leak that I managed them because it was discharged completely with no sign. And I managed them with TPN without any procedure and without any conversion to Roux-en-Y. But it's an exception. Mostly when we see there is a leak, we go inside the abdomen and convert it to Roux-en-Y. For the patient who had a leak, we should put gastrostomy, but sometimes you are tired and or the situation is not good, and putting gastrostomy, you know about gastrostomy placement, you should not like elective gastrostomy retract the stomach wall toward the abdominal wall. It won't come up. And we do gastrostomy there. It should be, and about gastrostomy, be aware if you put the gastrostomy on the antrum, it doesn't work for you. Be sure that because I have done, all of these are my experience, you should put it on the body of the stomach, gastrostomy, and it should not be reached to the abdominal wall, and we put a drain beside it, and it will work when we start feeding from gastrostomy tube. But if you had leak and you don't have gastrostomy tube, we do after we change to Roux-en-Y, when the drain is completely zero and no leak was detected by when the secretions are completely zero, we give methylene blue and then we start liquid diet. Or when it takes more than 3 weeks, for example, even in sleeve leaks, we convert to Roux-en-Y gastric bypass, and we have a very, very good experience about converting a sleeve leak to Roux-en-Y, and with this management, we make the time of hospitalization very lower than leak. Previously, in first my leak of a sleeve, I had more than 2 months the patient stayed in the hospital. But when we started to do for a sleeve leak, changing to Roux-en-Y, not completely pouch, only gastrojejunostomy and Roux-en-Y, we decreased the length of a stay to less than 3 weeks. After 3 weeks, if you have secretions, don't worry. Gradually remove. You have completely one track, and tract around your drain will completely collapse, and you can start liquid diet for the patient.
Okay, so Dr. Bazooki, in your experiences, does have any acute gastric dilation in the esophagus?
Acute gastric dilation, I have heard in the literature, and I have read, but I think because in laparoscopy we don't do more dissection, destruction of vagus nerve, or in my experience, among more than 2,500 cases of gastric bypass or mini gastric bypass, I didn't have even one case. Or maybe it happened, but it was not clinically important. Maybe we didn't have any problem. Yes.
Yes, Professor Bازوكي, Professor Singh. What about, I faced a case with leak. After 3 days when I checked, was all the field inflamed and the friable tissue.
After glycation.
After
Gastric glycation.
Gastric glycation.
Yes.
Not really bad.
What? No.
Yes.
In general. What about megastent?
What about?
Megastent.
Or leakage?
Megastent.
So what is
Endoscopic stent.
A stent. Yes.
So that I don't. So when you did open cases, you don't find too much inflammation, too much soft tissue. So that could you do the procedure? The thing that I would like to ask, first of all, about megastent. Secondly, as a staged operation to do jejunostomy feeding and then go back and correct the leaking problem.
تفضل. لا تفضل.
For leak after sleep gastrectomy, we don't have any patients. If our patients has leak after sleep gastrectomy, 500 patients. But we manage one case who is a police officer. She is 35 years old. She had the sleep gastrectomy in Brussels, in Belgium. And she flew back to the UK after 2 days, and she came to our hospital with acute abdomen. We did a CT scan with oral contrast, which showed leakage from the usual side, just 1 centimeter from gastro-esophageal junction. So we managed her, we took her immediately to theater. Of course, you start IV fluids, antibiotics, took her to theater, put the skull inside, and the abdomen is not nice. It's all inflamed, as you correctly say. Loads of fluids in the abdomen. So what we have done, we don't believe in a stent. Although there are many studies reported you can't manage a sleep, you need for a stent. We don't believe in a stent. What we have done, we washed the abdomen. We passed a T-tube through one of the ports to the site of the leakage, good size T-tube, and we narrowed with the stitches over the T-tube, and we put a drain around the T-tube, another big size drain. And then next day we brought her for another laparoscopy and washout. She went to ITU because of sepsis and organ failure. And I think she had 3 or 5 laparoscopy and washout. The most important thing here is to reduce the burden on physiology because of this septic process. Actually, she did very well and she went home.
You did put jejunostomy feeding tube for her?
We haven't. We fed her through the TPN. Actually, if you go through the literature, there is a big study. It is multi-center study in Europe to use a TPN on septic patients. They found thousands of patients. There will be no benefit to use feeding, intravenous feeding in the first week after sepsis. The patients will show benefit after 1 week. She has been fed on TPN, not intra feeding, slaving.
For how long?
She has been fed, I think, for 2 weeks or 3 weeks. She has been in ITU. This is the problem with the sleeves. Please listen to this. When you have a problem with the sleeve and leak from a sleeve, you are possibly costing, I'm talking about UK, there's one study showed one sleeve patients cost NHS 330,000 pounds from single leak, because you can't ITU admission, you can't repeated laparoscopy, instruments, and then you will end it up with unhappy patients. You prepare yourself for complaint and to answer 50 questions. Why you haven't done that? When you have taken the patients to theater, If the patients died in the UK, then you go to inquest. And in the inquest, if the judge found you are late to operate on the patients die, the case will go to High Court, and you will be prosecuted as manslaughter. So it is really hard, but I mean, I appreciate circumstances you work in. It's not easy as
الحمد لله
well.
احنا نشتغل بس عشان
But I think with your circumstances, if you have the precautions we have taken in London, and if you don't use gore buttressing, if you just put second layer of Vicro over a stable line, it will take you 20 minutes to suture it. But I think you save your life and your pocket.
One message.
If possible, I have a comment. I have only done, I think, only a few cases of plication. But Talipur and many surgeons do plication in our country. If you have a leak, there was a very good question in the first session who a general physician asked. And he told two persons were died because of dyspnea and something. Our country is like your country. In professor's country, they have CT scan which can do CT scan for heavy patients. But in our country, we don't have. And they don't accept to do CT scan for morbid obese patients. So every time you think that the patient is not very well, do diagnostic laparoscopy without delay. Without delay. Otherwise, your patient will die. If you delay, the patient will die. Even if you told your patients in private hospital, your amount of expense will be, for example, $5,000. Don't worry about your promise to the patient. Otherwise, you should pay more. Do as soon as possible diagnostic laparoscopy for the plicated patients only. Your suture should be removed and the stomach in the normal way and normal anatomy, and do leak test. If you see the leak place, suture it. Otherwise, only drain it and put, as professor said, a jejunostomy tube. All the problem will be resolved. And complete washing the abdomen is very important. If you think you can, if you are not advanced laparoscopist, don't do it by laparoscopy. Don't do it by laparoscopy because you will have more problems in future. But in contrary, and not like regular peritonitis that we completely open the abdomen from xiphoid to pubis, these patients, because open management of these patients are very difficult. All of these I have experience about them. In my first case of a sleeve who had leak, who was more than 200 kilograms, I opened and it was very difficult to manage the open abdomen and to close. So you should only incise from xiphoid till above the umbilicus, not even. As possible to do complete washing the abdomen. So, if you don't have enough experience, do a stitch. Remove your stitches for plication and do leak test and see the leak site, suture it, and do jejunostomy tube open or laparoscopically and wash the abdomen completely. About suturing after sleep, I have done and I have seen, as literature tells us, suturing doesn't, for example, for around the T-tube, only putting T-tube is enough, and suturing around it, like we do on biliary tract, and we want to have an intact T-tube placement, is not necessary, and be sure that these stitches will be disrupted and make more ischemia, and the hole will be more wider.